with that, I'm just going to turn the, Katie's still got to eat a little bit.
No, oh yeah, keep talking.
I'm going to.
Not too much though.
Then
They're
we'll
stealing
give,
my.
then we'll give it over to you
Okay,
to
good.
take over. Go ahead.
Maybe you're raising
Here.
just this goes.
A little further.
There you go.
All right.
Good.
Good? All righty. So I'm Josh Safer. I'm an endocrinologist. I'm the executive director of Mount Sinai's Center for Transgender Medicine and Surgery. I really owe major gratitude to Ken and to David Rich, who we mentioned, who really have demonstrated enormous institutional commitment to our program. The goal being for us to be an example of what academic medicine should be doing in this space to provide care for people, and then to lead in terms of the knowledge that's required to advance care for trans individuals.
I'm Marcy Bowers. My career started as an OBGYN. Delivered more than 2,000 babies during that time. Somewhere along the line, I went through my own personal journey, which included transition. But more importantly, I met a man named Stanley Biver, who is from Colorado, Trinidad actually, in the south part of the state. I met him in the year 2000. There was snow on the ground then, late in May. He planted a seed to maybe come there and learn the surgery he had been doing since 1969 in this very lonely, isolated location along the Santa Fe Trail. He had done so many surgeries, gender-affirming surgeries, that he's listed in the Guinness Book of World Records. I took over from him in 2003, practiced in Trinidad for about 8 years. Now I'm in the San Francisco Bay Area, but in 2016 was approached, thanks to Ken Davis, David Rich, many others, Barbara Warren, yourself. Josh wasn't in the picture yet, but they said, we'd like you to start this surgical program. And now we were the first fellowship to train future surgeons. We're now on our 5th fellow there at the institution. And it's a program that is meeting a need that has always been here. Trans persons have been around since the beginning of time, but it's a very, very difficult topic and a very difficult journey to take for people, as it still is. And but it's finally we've reached societal maturity, I'll call it, where we've been able to address the issue. We hope it doesn't get turned back and put everybody back in their gender boxes. You're assigned at birth, either male or female, and you go in your gender box, and a lot of people would like you to stay there forever. That's not the way the world is. I'll be quiet.
So, hi everyone, I'm Katie, and I hope you notice my glasses match my blazer. I'm really excited to have this conversation. I first met Josh and Marcy when I did a documentary for National Geographic called Gender Revolution in 2016. And I think the issue was, at that point, really about to permeate the national consciousness. And now I feel like, per usual, I was ahead of the curve. And so now, obviously, there's more conversation about transgender people, transgender issues, and I'm really excited to be here to help kind of lead this conversation. I think what was helpful when I did this documentary, and I think would be helpful moving forward for society as a whole, is to be able to ask questions, because it's still complicated and confusing for a lot of people. I wish in many ways this conversation could be for a much bigger group. Maybe Ken, at some point, we could talk about that for ideas, because I think it's really necessary for people to talk about these issues and to feel comfortable and ask stupid questions. And that's sort of how I got into this whole issue, from asking a stupid question on my daytime talk show. And if you want to learn more about that, you can read my book, Going There, available in paperback on June 28th. Anyway, so let's fast forward from 2016, when I did that documentary and met both of you for the first time, to today. The number of young people, as many probably at this table know, who identify as trans has nearly doubled in recent years, according to one study. And I guess this is based on a variety of CDC surveys. And according to those surveys, an estimated 1.4% of 13 to 17-year-olds and 1.3% of 18 to 24-year-olds are transgender, compared to 0.05% of adults. Clearly, we're witnessing this generational shift, with more people feeling comfortable coming forward and talking about this. But can you all take a moment and give me your give all of us your perspective about these rising numbers and what you think is going on here, in addition to perhaps societal acceptance and greater awareness? And Josh, why don't you start?
So to me, I think saying in addition to societal acceptance is actually not what I don't know if it's more than that, honestly. That is, to my brain, no matter how I'm thinking about things in terms of biology of gender identity, et cetera, these things have always been there, and so really all we're doing is creating safer and safer spaces and seeing that, which like I just said, has been there all along. What
do you think, Marcy?
Yeah, I think that's absolutely right. I mean, this is my little talking point, but all genitals are from the same tissues. All adult men have have estrogen, and all adult women have estrogen, have testosterone. And each male goes through a period where the genitals are female. So what people are trying to express is this, and then gender identity with all of its inputs from the environment, from genetics, from hormones, from experiential issues, trauma. This has an impact on how someone perceives themselves to be male or female. And so this is what this generation is trying to express, is that the idea of just defining them by male or female just doesn't make sense.
Do we have any more knowledge? I remember as part of my documentary, I talked to some scientists, but it was just so nascent in 2016. But do we have a deeper understanding at this point about what forces might be at work, Marcy, that you just described in terms of in utero development, some kind of hormonal bath or whatever that may be resulting in this? In someone feeling trans, or is it so multifactorial it's just hard to pinpoint?
I mean, you know, we had such a long conversation this morning. There's many ways you could look into it. Like, is there a gene? Well, that would be really going the wrong direction. Or is there something you can see on ultrasound? There probably is an area of gender identity that can be identified by brain MRI scans, and that's been shown that trans women look like cisgender women in the brain in this one particular area. But I think just more importantly, it's the fact that it's just gender identity is very complicated and it's very diverse, and this is just one more leg on the diversity trail.
Are you worried that as we explore how to quote unquote fix it, or what causes it, that will be taking a step backwards, that it's not celebrating our differences but trying to make us more homogenous?
That's exactly the point, is that it's really, we should be embracing this as diversity always makes the world better, and it's just, this is just one more fantastic, positive, open-ended opportunity that the world is beginning to explore. We don't want to shut that down and say,
yeah, I want to take an issue, though, with the idea of taking a step back. Because I don't actually, as a scientist, I don't think learning more about ourselves is taking a step back. I get how people are anxious about how things will be used, but as a scientist, I want to know more. And to me, gender identity and all the components, and notably, whatever those biological components are, that may include, maybe a gene is too simplistic, but whatever those components are, including things that are influenced by your environment, which are still biological components if you think about it, those are all of great interest to me, and it's not even focused only on transgender people, because I think we all have gender identity. And it's just that depending upon where your gender identity fits relative to some of your other biology, you may or may not have noticed. And as we take a step back and think about this more, then there's more capacity for us just to learn about the wondrousness of our biology. That's why.
But we don't want to push. We don't want to learn so that we can correct something or push people back in their gender boxes. That isn't the.
Oh, exactly. That's not the goal. It's the understanding of how we are. It would, I don't know what the appropriate analogy are. The simplistic analogy is eye color. We're not learning about all the biology that goes into the components of the eye because we're going to fix one.
So because we want everyone's eyes to be blue.
Exactly.
Yeah. Let's talk about puberty blockers, shall we?
Yeah.
The number of transgender teens has resulted in more focus on things like treatment, specifically puberty blockers, and I know the World Professional Organization for Transgender Health has been studying the best practices for this, and they're expected to release the new standards of care in September, right? Can you tell us some of the issues and that are being discussed? And I know you all might be able to give us, I mean, if you tell me, maybe you'll have to kill me, but a preview of what this organization or where it's coming down on, and what's sort of what the arguments are on either side.
Starting?
Well, I think we're still sworn to secrecy on the.
But there was a draft that was
details.
released publicly,
There was,
right?
yes.
Like the Supreme Court decision?
I'm sworn to less secrecy
Emily
than Marcy.
Braceland, who just wrote the article for the New York Times Magazine that was just published last week, she had access to the entire standard. So we were hoping that she would introduce some of those subjects. But I think if I can just summarize, and I always, no matter how I summarize it, somebody's going to say it was wrong, but I think the emphasis is going to be, because we're a scientific organization. We want to be doing the right thing. We want to allow people to explore aspects of gender without making a mistake or without doing harm. And so that's what these guidelines are all about. My feeling overriding all that is time, is that just the things we do, like blockers, is to give a person time. Blockers are safe, they are reversible for the most part, and that's the idea, is that you can block puberty before you get the secondary sex changes like a beard or a voice deepening, and while the child decides if that is really a path they want to go down. Anyway, the new standards are going to reflect greater self-autonomy and less gatekeeping, which is an argument we would get from the left, which would say that it should be surgery on demand, hormones on demand. I should be able to go into a vending machine and get estrogens or testosterone. There's nothing wrong with me mentally. Transgender used to be a mental health diagnosis, but we realize it's not now. Versus people that say, oh no, you need to go through these hoops, you need to see therapists, you need letters, which is the traditional method of how we've done things. So it's going to be listening to those people to say you have more autonomy over your life. Is that right?
Yeah,
No,
go ahead.
let me. So it depends what chapters we're talking about then too. Mm-hmm. So if we're looking, let's say, in terms of hormone therapy and having that simply be a medical decision and a conversation with your provider, there's going to be more of that and more autonomy. Where maybe some years ago we were more conservative. Now, certainly for adults, we'll be much more casual.
For adults. But what about for teenagers?
And and the question really was in that space, right? And similarly, by the way, for surgery, more liberal for adults.
For adults, yeah.
But
like we do an informed consent model, which is like what we do if somebody's going to have a facelift or a breast augmentation. It's an you make them aware of the risks and complications. There's always going to be some people that regret their decision, always, no matter what surgical procedure. But that's the model that is going to be increasingly relied upon.
Right,
For
for
adults.
adults.
For
Exactly.
adults.
Yeah, because I think the hot button issue is really about young people and teenagers, and that is where the conversation has become increasingly weaponized by politicians, which we don't need to start that yet. But I really want to know what you think the standard of care will be for the kids that I mentioned at the top of this conversation, the 13 to 17-year-olds and the 18 to 24-year-olds.
As we move to the kids, to the youth in that category, the important point is to be more conservative. And the reason to be more conservative is recognizing that there's going to be heterogeneity in terms of their ability to express themselves, to articulate themselves, and also to be thoughtful about the consequences of their decisions. And this doesn't really challenge their gender identity or their gender expression. It's just more a matter of thinking through how they're going to address all of this.
What do you mean conservative, though?
So where an adult, let's say I have an adult who's a college student, walks in to see me and asks for hormones, and they've got nothing going on. There's no medical anything. There no mental health concerns, and they're saying, I'm transgender, I've been doing blah, blah, blah since high school, and here I am in college, it's a perfect opportunity, and I'm ready for my hormones, and I've been thinking about this a lot, and these are all my thoughts and plans. And then I simply sit there as an endocrinologist, and I make sure that their thoughts and plans make sense. And if they don't, I advise them accordingly, and that's what I do with any of my patients who come for any treatment. That's an adult. A kid, same circumstance, comes in age 14, just walks into their pediatrician, they're not going to quite have it so casual. There's going to be a mental health component working through, so an extra pair of eyes at least beyond a pediatrician, working through what that kid is planning, trusting that kid a little less in terms of their understanding of the implications.
When you say working through, so I know there's a debate about mandatory therapy, for example, for young people, isn't there?
Historically, there was a mandatory therapy that will shift to more how I'm framing it, which is a mandatory extra pair of eyes, a mental health assessment, not therapy. There might not be any need for therapy per se.
Are you worried?
And that scares people.
Yeah, that scares people. Like, okay, so I'm like, okay. I think there are a lot of well-meaning people who worry about young people who are making such a decision. I know it, and maybe they don't understand, Marcy, that this is buying time for this individual, but they think this young person, adolescence is really hard and complicated. They're searching for belonging. The pandemic has only exacerbated feelings of loneliness and isolation. They're looking for identity. We all are, right, at some point, and community. Is sort of the greater acceptance in some areas. And I feel like, we want to be in a safe space. So if I say something wrong, you all correct me. But
we're as safe as you get.
Yeah, but I think we all need to have these conversations. People are really afraid of just asking, questions. But that they may not have, this is what I think people worry about. They may not have the maturity. They may not have the... They may not be, they may be going through the difficulties of adolescence, and they may be making a decision about their gender identity that they are not equipped to make. Right. And perhaps the medical establishment needs to be more careful and more conservative and make sure they do go through therapy before they are making such a big decision for themselves. And I'm curious how you would assuage some of the concerns that I think perhaps well-meaning, well-intentioned people have.
This is the quintessential question for this group. There's a doubt because people have their own kids. I have 3 kids. You know, they want to be firemen or fairy princesses or all sorts of things, and they change their mind and they end up being engineers or whatever. Kids change their mind about a lot of things, but one thing that is established very, very early and is almost immutable is the idea of gender identity. And you get that when you read the personal accounts of people who have had trans kids. There's just no way. They're just winning a losing battle. They try and try and try to reinforce assigned gender norms, and it's just met with misery and stress, and it's an everyday thing. And finally, when they finally give in to their child, things are better. Grades improve, their mental health is better. And this is what happens over and over again. But how do you, there's not really a good way to prove that gender identity is established at 4 or 5 or 6 years old. There are people that come out at puberty and later decide their gender identity is different. I mean, that's a very difficult argument to win.
So I would say that this is why we want this to be the domain of the medical system. And I don't want to get too hung up on therapy, not therapy. It's just having the people who know what they're talking about on the professional side being engaged in the conversation. I'm thinking of specific circumstances. I have teenagers who come to me, even as an adult endocrinologist, with parents, because I don't know how to deal with them without parents. That's the pediatrician domain. And they, and let's say a transgender girl, so male to female, comes in and says, and everything is fairly well established and stable, looking potentially for hormones even when they're coming to me now. This is even beyond puberty blockers. And I'll ask about fertility plans, like has there been sperm banking? Is there any thought of that? And the kid will say, oh, for sure not, I'm not having kids. And the parent will say, will interrupt and will say, oh, yes, we'll be doing sperm banking. I'll make the appointment, honey, and we'll be back in a month, doctor. And so it gets at, you know, it does, that's a very different conversation than at the adult level. And so I guess I'm open to that. I don't think that's a bad thing that just happened in my office. Right, and that you know, a little bit of that voice of reason and a little bit of that conservative ingredient into the conversation.
This is what they're afraid of. They're afraid of Munchausen's by proxy, where parents are actually living through their children. They're afraid of the kids being swept up by their peers. So like this, you know, or recruiting or social pressure, and to join or be inclusive. And that's something that we, you know, have to, in WPATH, have to, you know, we have to put that in. But again, it gets back to that issue of what we want is not gatekeeping. We just want time and very reasoned and well-informed decision making.
But given the fact that our notion of gender has expanded so much, and I think, you know, when I did the documentary, I think there were like 45 different descriptions for gender on Facebook or something like that. How do you know, for example, if someone is gender nonconforming, right, versus transgender? And and because when you introduce a medical intervention, right, even if it is to buy time, it is a medical intervention, right? So how do you make that determination?
So I want to come back to, I'm not in, well, the quick answer to the question itself is, I don't need to make a determination across all of that granularity. I really am just trying to decide if the person requires a medical intervention or not. And so in that sense, it's a little bit more simplistic. And the kids who come to see me, the older teenagers, that is, or the young adults, I'm calling them all kids, are label themselves in myriad ways and more ways than they used to. But at the end of the day, my interventions are still somewhat simplistic. I've got hormones or not hormones, or surgeries subsequently. I want to say one other thing, though, because we were talking about puberty blockers, and I want it to be clear that puberty blockers are a conservative small c intervention, certainly for a year or two. And so the idea, so that's also really important for people to recognize. That's a safe place to go when more deliberation is required, or should be considered that. And the fact that people are targeting that does not make sense to me medically.
But they feel like once you're on the treadmill, you're unlikely to want to get off. Once you socially transition, you're unlikely to want to get off. And how do you safeguard against that?
I hear that fear, but I don't actually think that's what we're seeing. I think we're being very conscientious about who we bring into care. And so it's really true, most of the kids who are getting on puberty blockers go on to subsequent treatment.
And Norman Spack, who was at Boston Children's, who started the idea of puberty blockade before they went through later stages of puberty, using puberty blockers. He used to say, though, that the way to really determine whether somebody was a candidate for puberty blockers is if they found the prospects of puberty itself, the physical changes of puberty, extremely dysphoric.
Although I'm not even going there. I know people used to say that. Some people still say that. I don't actually even say that.
You don't even say that?
No.
Um,
Well, what is the trigger to go on blockers then? What do you say? What do you?
Somebody who is entering puberty, where it's the puberty that does not align with their gender identity, in all its complexity, who needs time to think about what it is they really are imagining and what they're thinking they're going to do, that person's a candidate for puberty blockers. These large numbers of kids who are hearing, who are saying that they're transgender right now, for what it's worth, the largest growth is among those who are saying that they're non-binary, which to me means they're recognizing a spectrum of gender identity, but I'm not expecting that I'm going to see all of them looking for actual medical interventions.
Got it. You all are so well versed in all this, and your expertise is kind of unparalleled. But I think also the concern is Mount Sinai is one of the leaders in this field, and yet you all are terribly under-resourced. This is kind of a nascent field for both, in the medical establishment. And I'm curious how worried you are about other healthcare providers not making the right decisions for some of these young people, and maybe not being properly trained, because certainly there aren't enough people in the field, right?
That's an enormous point, and absolutely the case. We are struggling, led actually historically, and still she's still our surgical guru in the surgical field, trying to deliver care just in the New York area. Although I think 2/3 of our patients now come from around the United States. And so that's in that space. As we start to expand, when we think about pediatric and adolescent care and how to be and in an appropriately sophisticated place, that is when you talk about underfunded underfunded places in medicine, that is one. And we're seeing that. I mean, we're seeing that in New York at every level. I have parents with a whole range of resources.
Well, this is the problem with the legislative attempts. They've
right.
seen this problem, and so one of our colleagues, shouting out about how the care is inappropriate. I will say the providers I know are extremely conscientious, extremely connected, extremely well thought out, using science and objectivity to treat. And what we don't want to have is the prescription and implementation of medical therapies that have permanent effects on people that are so young. And so that is that aspect, that policing and the expansion of education has been central to WPATH's mission over at least the last 5 to 8 years.
Right, that's a good point. So expanding the number of knowledgeable providers, not just expanding access. But the whole access piece is, I mean, the specific, so we all, I mean, that's part of that, what precipitated this conversation today originally was some of what's going on in these legislatures where they're basically trying to legislate healthcare delivery, which never makes any sense. It's scary to me as a doctor at every level, whatever my politics or the politics of my colleagues. And
because
yeah.
they always get it wrong. They always
Exactly.
overreach. They always, that you can't legislate. But now they're wading into abortion, women's health care. This is a terrifying time. It's a real tipping point for any medical system.
And
We have got, like you were mentioning earlier, we've got to keep that separate. Legislative bodies need to stay out of healthcare.
Well, good luck to you on that, because to date, about 150 anti-trans bills have been introduced to state house floors around the country, and that's in 2022 alone.
Yeah, it's crazy.
So they range from banning treatment, criminalizing parents, outlawing gender-neutral bathrooms, prohibiting trans students in sports. We're going to talk more about that in a moment. But what impact, because honestly, it feels like this train has kind of left the station in many of these state houses. And what are your biggest concerns about the impact many of these pieces of legislation are going to have, not only on trans patients, but trans physicians as well?
Well, they're burdening the people who are actually residing in those states are obviously now become targets themselves, which is crazy. Even those of us who are in other states are then bearing some of that burden. We've had reach out already at Mount Sinai from families from Florida because their care is suddenly evaporating. And they're wondering, and these are not even the least resource families who've got no options. These are middle tier resource families, I would characterize them, who are saying, well, we could afford to fly up to New York once or twice a year. Would you be willing to see my child?
And we do have a paucity of data on treating trans youth. However, we do know that suicidality and poor psychosocial functioning is associated with a lack of access to care. So we know that as a fact.
What can be done about this legislation and this runaway train, as I described it? Is there any, obviously, President Biden just announced support for transgender people. I can't remember exactly what that legislation said or what he wants to do. Do you all know exactly?
I just heard just a loose
It happened like
description
2
of it.
days ago.
Yeah.
Honestly, I should have written it and put in my questions. But
Sure, I was concerned.
there's the other side that's trying to protect trans patients. But in terms of these states, does anybody know? Anybody want to chip in?
It was Title IX. We looked at Title IX, which is about sex discrimination in schools, and interpreted it in a way that would allow
Gender-neutral
kids to play,
bathrooms.
in sports teams as well.
Right.
So by interpreting Title IX by gender identity, that was the big.
Right, but I guess the question is, how much authority will he have over kind of what's happening at the state level? So, when you all hear about all this legislation that's being passed in state after state after state, by the way, the same states that are outlawing abortion pretty much, is there any recourse?
Recourse. I don't know. I have fantasies. Which are more wondering. Are there any? Where are the allies? Specifically here, we're talking on people who label themselves more conservative or label themselves as Republican. I'm who simply to let healthcare be healthcare among patients and doctors, and even to use their own local resources. I just came from the Endocrine Society main annual conference. I can assure you that the physicians have a broad range of political opinions on subjects that are genuinely political. There are plenty of people who label themselves conservatives and Republicans and Democrats and liberals, and there's much to debate over a drink late at night after the conference. But specifics of healthcare and evidence-based healthcare is not one of those subjects. And even within transgender care, we can talk even about some of the nuances that we might be discussing in terms of when is an appropriate time to start puberty blockers, for example, in a given individual. So we're having those conversations. But like I just said, when to deliver care, or to deliver care, that's not a question, and it's a threat to all of us across the political spectrum among physicians.
But a lot of this is all, this is a reflection of the voter bloc who is asking these questions and not getting answers. And so part of our responsibility, whether it's through the media, whether it's through op-eds or whatever we can do in WPATH, that's what I intend to do as the incoming president, is to get out and tell these stories, not only from medical providers, from clinicians, but also from patients and families about what they're experiencing, and you've got to reach people through their hearts. You've got to understand their fears, you've got to address their fears, and you've got to show them that our organization and the people that represent our organization are delivering care in a thoughtful way that has checks and balances, that is going to be responsible and open and honest.
Go ahead. Did you want to say
No,
something?
no, I
Josh?
totally agree. I think we've even had these conversations where you say, well, this is, I'm going to ask the question that I know many Americans have because they're afraid of too much of this or too much of that or some
Being
epidemic.
canceled or whatever.
And I think we have to address those questions because we don't want to be going there either. Exactly.
Let's talk about a thorny subject, which is detransitioning. And I think sometimes the media misrepresents sort of the percentage of people who detransition. And I know that Christina Olson's study, and I interviewed her for my documentary as well, showed that only 2.5 teens reverted to their gender assigned at birth after 5 years. That study has been criticized for not having as many people of color in it and for some other reasons. But can you give us some perspective about detransitioning and sort of why that's become kind of a bugaboo for the anti-trans forces in the country?
It's really a shame because, as I say, any medical procedure, hip replacement is associated with as much as 20% regret. But when you come to trans and trans treatment, trans surgery, with all of the difficulties, I mean, it's not an easy process existing as a transgender person with discrimination and housing issues and employment issues. It's a wonder more people don't go back. But if you look at any 50-year longitudinal studies, there are a lot. The Cornell University meta-analysis of more than 4,000 studies of transgender outcomes showed that the results were overwhelming. 93% had a favorable improvement in their psychosocial standing, their self-esteem, their relationship improvements. And regret was exceedingly rare. In all studies, always less than 2%, most less than 1%. It's still a very, very, and the kind of regret, I want to talk about regret because Josh says it, you think it's acting defensive, but it's not. That's what people want to know, is that how many people actually change their mind. Like, the first thing I get in any interview I ever do is how many people change their mind, and it's exceedingly rare. And when you do break it down, it's usually because people can't find a relationship or they can't find employment. There is a small percent that have regret because of the surgical outcome. If surgery is really bad, they do regret it and they go back sometimes. But the type that they're most worried about is that constitutional, I just changed my mind, I'm really actually just I'm really a woman, I'm not a man after all. And
Well,
they
it's
wanna
also,
go
you know,
back.
like women who lose a bunch of weight think suddenly their life is going to change and everything's going to be better, right?
Yeah.
And there are probably people who have underlying problems who transitioning doesn't solve all of their problems, right?
That's true. Then there may be more than what we're seeing. I mean, there's some evidence that they don't come back to their provider to tell them that they actually they detransitioned or went off hormones or regretted, let's say mastectomy or something. But it's still a very, very small number. But those people are being propped on a pedestal and then paraded around as being an example of why transgender care is failing. It's simply not true.
And I think there are two conversations here too. So one of them is comes from some just anti-trans, I don't know what it is, or using transgender people as some sort of political target
Right.
For other purposes. And that's looking to see what sticks, looking at every little negative nuance that might exist in the field and trying to exaggerate that. So that's one conversation, but there's the separate conversation, which is amongst us medical people, where we do really want perfection if we can get it. We want all our medicines to have no side effects and all our surgeries to always work, et cetera. And so when we're looking at, that's our medical context, and I don't want that conversation where when we do have people say, well, I made this decision and I'm sorry about that, where we think about how we could do better in helping them and helping lead them correctly. So we do want to have that conversation, but
And
we
I'll
don't
say
want to conflate it or take it
Right.
out of context.
In the new standards of care, detransition is going to be something that's tracked and followed. It's actually addressed in the new standards of care. Even though it's a small minority, it needs to be recognized and dealt with and talked about. There needs to be room for people to voice their concerns if they have a regret. And as we see more people filling in that middle of gender diversity, it's understandable that if you're not going to one polar extreme or the other, that you may waver in your decision making. There's going to be more regret. It's going to be a fact. So that means that we need to really turn the table around to the individual to say, look, these are permanent, life-altering decisions that you're making, whether it's hormones or surgery. You need to take personal accountability of what decisions you're making. This isn't just a provider. You don't go into a provider in a passive manner to say, well, the doctor told me to do this. You want to go in, this is your life, your decision. We're here just to help you.
And I want to actually take that back to the kids a second, because the fear is, oh, a kid can't make that judgment call. But the good news is that the interventions that we use for kids are either reversible or have relatively more modest consequences. And so we don't actually do the things that require that conversation until adulthood.
I think a lot of people don't understand sort of social transitioning and when medical intervention, even if it's conservative, because I think uninformed people are like, wait, they're going to make these huge rash decisions and they're too young to do it. And I don't think they actually understand the medical
They think we're operating on children.
They do.
Yeah, they think we're treating children with hormones. We don't do that.
Yeah, and I think that, an educational campaign to really help people. I mean, I tried to do that with my documentary, but, we need to keep doing that so people actually have the information, because they have opinions without portfolio. And I think it's very misleading for the general public. I want to open it up to the table because we have a lot of smart people here, but first I want to ask two more quick questions.
I want to sneak in one more thing on the regret, on
Yeah.
that little regret piece, because yes, everything you said, and thank you for your documentary too. But I've had the conversation with a father not long ago with a transgender boy, female to male, late teenager, very well established, everything pretty clear where we're going, starting on testosterone. Father very nervous, exactly for regret and long-term consequence issues. So we talked it through, and I said, let's just say, for the sake of argument, it's a 1% chance. Probably not even with your kid, but 1% chance then, and at 24, your child is going to say, this was a mistake, and we just talked it through. What is testosterone going to do for the next 5 years? And your child's going to have a lower voice, and is going to have maybe a little bit of facial hair here, and you're going to have a little cosmetic conversation that you're going to have, and I think that's about it. And the fertility not affected. And father, we're not talking any surgeries at this point. Father says that was just digesting that, saying, well, right. That's a risk. Then it became a very quantifiable risk, and much easier thing to wrap his head around.
Marcy, I wondered about this when I was preparing these questions and reading sort of the latest articles. Now that there's such a spectrum of gender identity. Mm-hmm. And I see it with my daughter's friend. She's 26. It's just really interesting generationally, kind of what's happening. Do you find that fewer people are seeking gender confirmation surgery because of a greater acceptance of all kinds of gender identity and the way you present yourself to the world? I'm just curious about that.
Yeah, I think that's a fascinating I think this is a paradigm shift, how we look at gender. I really think that the days of thinking of gender as two polar binaries is going to go away. It's the natural order. It's who we are as human beings, and people are living increasingly honestly. And so I do think that that actually will be a trend, is that people will say, you know, it's okay to be a woman with a penis or a man with breasts, maybe. That may be...
And do you see it in your practice? Do you see it yet?
I'm at the very end of a very, focused food chain in the
Yeah.
sense that I'm really...
It might be maybe more Josh. I mean, do you see kind of a comfort in sort of all kinds of anatomical situations for people who are trans?
I can't give you a statistic yet. For a change, I can tell you that it has been the case already for quite a number of years that maybe 60% or so of the transgender women in my practice are looking for genital surgeries, and 40% are not. And with a whole range of reasons not, and I can't tell you if that number is growing though, but I can say that's already an existing situation where people are like, that's in my pants, that's between myself and my significant other,
Right.
or even, I don't even want to, I'm nervous about a surgery and injuring nerves, and I'll keep those body parts or whatever their logic pattern.
Well, apparently I said that when we first met at Grand Rounds 7 years ago. I think I said in my talk, I said, when is the last time
Thank you.
you passed someone on the street and knew with 100% certainty what their genitals look like?
I use that line.
It doesn't happen.
Yeah.
Make assumptions about people based on their gender expression.
Let me ask you about sports, because FINA, the organization that oversees competitive swimming, ruled that transgender athletes who have experienced any part of male puberty cannot participate in women's events, with some claiming fairness more important than inclusivity. Those are their words. The NCAA and the IOC are both looking at this issue for other sports. So what are your thoughts on all of this? And should, for example, the Penn swimmer, Leah, be able to compete against female swimmers when she transitioned, I think, quite late, and is crushing it?
So she benefited from the male hormones and
Yeah.
Testosterone as a performance enhancing drug almost.
If I were a female swimmer, I'd be like, I'm sorry, I'm not competing against you.
This is a tough issue, but remember this was all litigated in the popular press in the 1970s with Renee Richards, who was a male mid-level tennis player and sued the Women's Tennis Association to play, and of course the fear was that he would come in and dominate. Then she, as Renee, would dominate all the women's events, and of course what happened, she went from being a mid-level male tennis player to being a mid-level female tennis player, and everybody stopped talking about it. And
But in this case,
well, still most sport is a matter of finesse. Now, something like swimming, basketball, how do you take someone who's 6'10" and say, is it really fair if that person transitions to female that she can come in and dunk all over these cisgender girls? I mean, it's tough.
Well, as I'm just a doctor, so I can't comment on that fairness inclusivity argument. That the IOC will have to you'll have to ask them. But speaking in my space, what I don't want us to do is get ahead of the data. So we have much bias in how we think, and that and I think Marcy, your Renee Richards story goes there. So you could envision, if we're talking about, let's say, runners, that a transgender woman who's gone through what we consider a typically male puberty and has a bigger body and bigger bone structure that does not go away when we do our hormone treatments, but also has larger muscles that do shrink a little bit, relatively speaking, at least.
Well, they equilibrate. After 2 years on hormones, the muscle mass of transgender women equilibrates with that of a similarly sized.
But you told me
Cisgender
in our
woman.
pre-interview that that's kind of mushy, that it may be 5 years, remember?
Well, I
Didn't you
forgot.
talk
I
about
just
that?
Well,
forgot.
that-
I don't know what the, I forgot what the number was. I thought it was 2 years, but
But,
maybe
but,
it's-
what, but
but
my
I guess
point
the-
is, like, those 2 years, if that person is competing,
well, they're not allowed, they wouldn't be
Well,
allowed.
no, so the
to
point though,
even-
Yeah.
first of all, I just want to raise up the point that it could be the opposite. You could envision that in certain running distances, the transgender woman is at a disadvantage because she's actually taking a larger body around with smaller muscles. And that's part of why we won't see so many transgender women in that space. They may be bigger, and your bias may be, oh, they're going to do better, but they're actually not. They're not going to jump as well. Or consider the basketball player example. Maybe they won't jump. Their jumping ability, depending upon which position we're talking, whether it's forward, versus center.
Basketball's that's,
So,
I don't think you can win that one.
no matter, but it doesn't matter because the point to me isn't
But
to
it's
have a
still-
debate about it.
it's-
It's to think about what the data are and not get ahead of our data when we discriminate.
It's muscle mass, it's conditioning, and it's finesse. That's what most of sport is. Golfing, tennis.
Well, there are certain sports that are already co-ed, which I guess would fall under the finesse, even in the Olympics. And so that they don't. So we already know that doesn't even have to apply in those spaces. Things that are dependent on hand-eye coordination or use of a tool or equestrian events, things like that. And for the other events, right, you can envision, and I can tell you because I'm involved with some of these international organizations. Some of the conversation really does go to what makes sense for this event. So for a longer distance run, where you are more dependent on stamina and oxygenation and things like that, and your overall body size maybe isn't helping you, you could envision a slightly different role than for a sprint, where upper body strength and upper body size that might have been different in a typically male versus a typically female puberty might still be relevant.
I can tell you a couple things. Just I've operated on at least 5 girls who are puberty blocked very, very early and are competing in NCAA events secretly. So they're already out there, and they're not. You would never know, and nor are they ever going to tell anyone. But they're very much considered equal with their peers, and I just can't. I think saying any male puberty is going to be really unfair. But probably we're going to have to draw some sort of line as a compromise to say that that it doesn't. I have 2 daughters. I just it's hard. You want fairness, I think, above all, and so. No question, if they're blocked that early and they transition in childhood, they are girls. But there is a point maybe where there does become a competitive advantage, and I don't know what that is.
so it's complicated. And when do you think the data, for all these different sports might be available in term, and isn't it hard to quantify that, Josh, when every individual is different and their biology is different and their development and hormones and yada, yada, yada?
Yeah, some of these data are going to come never, right? And we do have to look through it through the lens of how much diversity we already allow. And this has come up at the international level where, for example, at the Olympic level, some of the way they create diversity on a platform is by having different sports that favor different body types. And because they don't know a different way to do it. So nobody spends too much energy worrying about the fact that the Dutch basketball team is taller than the Guatemalan basketball team, and that we just accept some of that. So there's a degree of that we're going to have to accept.
That's true. Yeah.
I'd love to open it up for questions. We have a hand mic here, and
Let me make a comment or two. As a mercenary CEO, and I'm a mercenary CEO, and one of the things that's so interesting about what you talked about is that at least 1% of the population identifies themselves as transgender. That's a huge number of
Pew
people.
Research last week said 5%. That's 6 million people
Okay,
are saying.
so what that means is there should be a huge waiting list, that we are not meeting the demand. And as I see it at Mount Sinai, the hardest part we have, and you know this, Marcy, is finding more surgeons. If we could find more surgeons, we could do more surgery, we could do more of this. How are we going to get over the training problem? How are we going to ultimately meet the needs of what is real in the population? What are your thoughts?
There's a tension between having enough of a trained workforce and having a correctly trained workforce. And I think we've talked about this in two different spaces. We talked about it among the kids, where we want access to care, but we don't want everybody being put on hormones by providers who don't know what they're doing, where the kids may not be appropriate for them. And I think that's true for surgery too. Obviously, we at Mount Sinai, with a program where, Marcy, you are a founding member, where we're trying to train more people, I think we need to put more energy into that. Others don't have that and could. Actually, we maybe could train even more people, and I think, in my mind, that's where I'd focus my energy, so that the larger numbers are also trained people.
Marcy, I want to hear from you,
I
but
mean,
part
there's
of
gonna-
the issue,
there's gonna be a
is,
lag, but there's so many, the number of people who are coming through, the young people that want to go into this is overwhelming. There, you will see the next generation.
Right, we don't have a shortage
wave
of
people,
interest. That's true.
That, you know, our neurosurgeon, his daughter is working in my office now. She doesn't want to do neurosurgery, she wants to do transgender
Right.
surgery.
but this could be 10 years away.
Sure, but it's coming.
It's coming. But right now,
And I'm sorry.
go ahead, in my generation, when I had this first conversation with Michael Marin,
Oh, yeah.
I mean, he like rolled his eyes. He said, "Really? We're going to do this program? I don't have any surgeons who want to do that kind of work." Right? That's what the surgery's for. It's changing, but I think at least for the next decade, we're still going to have a shortage of people who can do the surgery, and it's sad.
What about telehealth? Is there a role for telehealth in some of these states where they're enacting these very restrictive laws? Is that obviously not for surgery, Marcy, but for the kind of work that you do, Josh?
There should be a role for telehealth.
I think they're taking it away, aren't they?
Yes.
They allowed it, and now they're going to take it back.
We actually had video during various emergency regulations because of COVID, and we're losing some of it because we're regressing to the individual states and their various licensing requirements. I know there's actually interest in Washington to think about that in terms of interstate commerce. I don't know how people work around where the idea where you would be allowed, where there would states would be obligated to grant each other reciprocity in this space, but I haven't heard of that actually moving anywhere recently.
Anyone else have some questions here? Oh, you have a mic there, great.
None of you have used the word insurance. Is it fair to assume that insurance companies are covering this at all levels? Any pushback there?
I mean, I can tell you that when I moved from Colorado to California, fewer than 5% of my patients were covered by insurance. And thanks to some very notable studies about access to care and how important that was, that number has flipped so that 95% of my patients now are covered by insurance. Wow. Most of it commercial. State Medicaids also have come around, but again, it also divides out where that company is headquartered. So if they're headquartered in a conservative state, they do not have to cover. I think it's 21 states now mandate coverage, though, for companies with more than 100 employees. And the HRC, Human Rights Commission, puts out a equality index where you cannot get 100% for your company unless you have transgender coverage.
When the Medicare ban on care ended in 2015, these states that Marcy referenced started mandating coverage for most of their payers. I will tell you, having spoken with many medical directors at that time period from insurance companies, really, because gender-affirming care, including the surgeries, is not actually very expensive from an insurance company's perspective relative to other costs. That their biggest focus was on getting it right in terms of the care coverage for their patient population, so that their staff could focus on more expensive things, whether it be in cancer treatment or where we have some developments that are far more expensive. Mount Sinai gets a gold star here, in being very influential in the space in getting some of the managed Medicaid providers in New York to also cover it, and that actually is still a bit of a gap even in these states where the commercial insurers are covering.
My concern is not making the decision to go ahead in that direction, but who's going to make the decision. Because I'm concerned that there are a few people like the two of you who are out there in the community, and I know that I was a card-carrying endocrinologist, and I was never trained in that special or subspecialty area, but I'm concerned that people on the street, I shouldn't say the doctors in the community, who are not trained even in endocrine, are going to be asked to write prescriptions without really knowing that much about the side effects, the questions to ask, sperm banking, things like that. I commend Mount Sinai for having that kind of luxury to offer the patients that make it there, but what are you going to do about the others? And I was sharing with Josh, if the doctor doesn't prescribe these medicines, virtually every pill you want can be bought on the street.
Well, I can tell you, though, that this was part of the WPAS initiative. They started the Global Education Initiative, which now they call it Institute, and that is to do education for providers around the world. Thanks to Zoom, now it's all of those conferences are very, very well attended, and that has greatly expanded the educational reach that we have.
Yeah, the educational need is big. Global Education Initiative is important. The Society for Program Directors, you'll be happy to hear in endocrinology, adopted last month a curriculum for program directors who are at institutions where they do not have a large transgender program, to make sure that future endocrinologists are trained.
But transgender training in medical education is very rare. And I spoke at Stanford University Medical School, and then the reward was lunch with the dean, and I asked that question, and he said the reason is because board examination questions do not ask transgender questions. And until they start putting those on board exams, curriculum will not follow that.
Anyone else have any questions before? Yeah.
So I really have a two-part question.
Oh, here.
I think
Yeah, I got it. Here you go.
I have a two-part question. I think one goes to Dr. Safer and the other to Dr. Bowers. The question relates to the puberty blockers. It seems to me that one of the many constitutional infirmities in the legislation that is being proposed in various states is that it outlaws the use of puberty blockers for trans kids, but in some cases explicitly allows their continued use for cisgender children, such as for treatment of precocious puberty. And I wonder if there's any evidence, Dr. Safer, that it's safer for cisgender girls to undergo precocious puberty treatment with puberty blockers, but not for transgender children. And then for Dr. Bowers, I wonder with regard to puberty blockers, when you have a patient who reaches the age of majority, but has been on puberty blockers for some extended period of time, are you concerned in consenting them that they are, in effect, sexually naive and that they've never been through sexual intercourse with their assigned genitalia and may not know what they're giving out?
Mm-hmm. Yeah, these are great questions. So there are kind of, and even the one to me has two elements to it. At the political level, it seems straightforward and it's discrimination. I'm hopeful that's a weakness, actually, and gets struck down at some point pretty quickly. In terms of just simple safety, everything being the same, yes. Why would I say it's different? But now if I want to get a little deeper and talk about it from a medical perspective, if we're thinking about fertility and sexual function, then the cisgender and the transgender kids are using those, are getting those puberty blockers in slightly different ways with different experiences to follow. So if I've got a cisgender kid who gets a puberty blocker and then stops that puberty blocker and goes through their natural puberty, they get that sexual function and that fertility, and I really got nothing. It's pretty safe. When I'm dealing with a transgender child, that kid is going to maybe move to hormones to match gender identity and not go through their natural puberty. And it may be the case that that should influence when I want to institute puberty blockers for the transgender child. Nothing to do with the legal side of it here. This is just thinking from a medical perspective, where maybe I want for a transgender girl specifically to institute puberty blockers a little later in puberty, after she has spermatogenesis, after she has, so that after there's some sexual development, and then when she moves on, as she likely will, to hormones to match gender identity, she will have some of that in place.
Yes. And so that overlaps a little bit with what I would say, which is that the orgasm part of it is what I brought this, unfortunately, I interviewed with a person that had some very conservative leanings, so sort of amplified and inflamed my comments, but in a way that's been weaponized by...
Welcome to modern media.
I know, and I'm so naive. I talk to anyone, and but when you institute puberty blockers at Tanner stage 2, one, you assure that person's never going to be able to reproduce. There's no way to extract sperm. Or now I'm talking. My concern is really with the assigned male trans feminine persons. That's who I mainly deal with in my surgical practice. The assigned female at birth, when they go on puberty blockers to prevent, like breast development or whatever, they have raging hormones once they're on testosterone, and they have no problem with sexual function. So they go on and they have a very active sexual life because they're men. The assigned male trans feminine ones, though, never see testosterone in their life. And that was the concern that I started bringing up 5 years ago. I don't regret doing that article with Abigail Schreier because it's got people talking. The second point that I see that I still don't think has been addressed fully is that we lock them in at a development stage in their genitalia that is infantile. So they have teeny tiny little penises. Those are what we have to make the adult genitalia out of. And we've had to scramble, and I don't think entirely successfully yet so I don't think the surgery is as good, and that's my concern. So I've been, and you see me, you saw me in the New York Times article. My feeling is that if I had a child who was transgender, I would do whatever I could to get them through a little bit of puberty. 1, so I can have grandchildren. 2, so they can have a sexual function, because once you establish orgasm, no matter what, it's so high, the percentage that are able to do it after surgery. And then the third is that they would have enough of that we can create an adult, realistic vagina that they can be sexual with in that way as well. So I think it's really, for me, I hope I'm changing the informed consent model for people when they talk to children, because I don't think that anyone has ever really been able to put themselves and do true informed consent. And it's this wave of kids now that are just coming of age, readying themselves for surgery, that I'm concerned about, because I've dealt with hundreds of them already, and they're all very, very difficult.
Then that trans female couldn't be a competitive swimmer.
And they can't even be a competitive swimmer.
Well, so there's nuance there too, and so I really want to. Marcy's really been out in front in and this is just misogyny if you think about it. We're not thinking about transgender women as sexual beings.
Well, because we never give testosterone back. You say, it's different. That if you have precocious puberty, You go off your blockers, you go right through a female puberty, and women have testosterone. Otherwise, we wouldn't even be on the planet. No one would want to have sex. But we don't do that. We don't do that for our trans feminine growth. We don't give testosterone,
Right.
and so they never, in my experience, they're never orgasmic.
Yeah, no, we're on the same page. But I'm mostly giving credit to Marcy for really bringing this issue up, and it's part of the reason you got my more nuanced answer, where we should not be discriminating against transgender kids, but medically we do have to think about when we're instituting the puberty blockers, because it might be at a different time point in development, so we can, especially with the transgender girls, get them a little bit of a male puberty. And to the not being allowed to be a swimmer point, we have to be careful there too, because then people are beginning to say, oh, well, if they got puberty blockers at puberty onset, at 10 or 2, which is the official definition of the beginning of puberty, then it will be okay. But if you say then and only then, it's a bit of a problem.
That's a shame.
And puberty really extends, it actually extends beyond the labeled Tanner stages. Muscle development and athletic development they're not even part of the Tanner staging system. You're through at Tanner 5, which is the last of the Tanner stages, before you have quite a bit of that development. So I think there's opportunity to nuance it, and I think as we start to think about what the rules should be, where we say, puberty blockers during puberty is okay for the athlete, and I think and I think we'll get away with that, but we have to just pay attention. If you say absolute beginning, well, I don't even know when that is.
Right.
Because even Tanner 2, what does that mean? It means you've seen something. So I've already been asked by various lawyers from various states trying to impose these bans. Well, doctor, if you can see something, doesn't that mean there was a little testosterone floating? And maybe they already have an advantage. And so we can't be absolute.
So I run the Sports and Society program here at the Institute, and most of our work is with it. Hello, hello.
Oh,
That's good.
There we go. So I run the Sports and Society program here at the Institute, and most of our work is within something called Project Play, which Mount Sinai was involved with in Harlem as well. And it's all about building healthy children and communities through sports. So we work really, really hard at gathering the data, finding the gaps, identifying the barriers, figuring out how to address those barriers or otherwise. And so we made the statement, of course, that all children, including all kids LGBTQ, should have an opportunity to play sports. People need to figure it out. We have not dived deep on this question of the state laws related to drawing up those lines. And one of the reasons I haven't gone deep on that is because I feel like I'm hearing from the voices that are not actually affected. You hear strong voices on the right, legislators, people who presume certain things, they're driving this stuff, and then you hear strong voices on the left. But what I really want to hear from are trans teenagers and what they actually, trans teenage athletes and what they actually want, and how large of a population is that? How much demand is there for playing interscholastic sports, which is one form of sports? There's all sorts of sports, and just because there's so maybe you can give me some insight. How much demand is? How large of a population is there of true high school kids who want to play, play women's sports, and how strongly do they feel about this being a priority?
I want to give you the endocrinologist answer fast, which is demand is not high enough. That is, it should be higher. Whatever it is, it's too little. That we have too few people involved in sport at any level for good health of the population. And that's really what I see as an endocrinologist, getting outside my trans space and into the general endocrine space, are people who have weight issues and diabetes risk, et cetera, and are not engaged sufficiently. And opportunities to get more people engaged is really the need, if I'm talking about a social need.
Mm-hmm. Yeah, I've heard this before. It's just like, it's just not a problem. It's just so tiny, the number. But then you get a Leah Thomas that it stands out and is cleaning up. But, remember, I mean, the IOC and the NCAA went through this, in the 1980s when they had the East German swimmers being, doping their female athletes and winning all the races. Clearly, anabolic steroids are a performance-enhancing drug, and so they went back and they said, how are we gonna decide if somebody's really able to compete? And so the problem with measuring sex is that there's like 9 different measures of sex. Because there's chromosomal sex. Well, if you start testing female athletes for that, as they did in the Olympics, there's this condition called androgen insensitivity syndrome, where they are 46XY. 11 of the athletes, when they tested the Olympics in the whatever it was, had 46XY. They didn't know it. They were assigned female. They have female genitalia, but they don't respond to testosterone. So how do you tell that girl that she's not a girl? Of course she's a girl. And then you look at hormonal sex, and there's overlap between male and female, whether you measure estrogen or testosterone. There are some women that run very high levels of androgens. I mean, we know them. It just happens. Men that run higher levels of estrogen. This is the muddy waters that they waded into, and so they decided that, they took that 2-year, that was the exercise physiology testing, and they decided that's when muscle mass equilibrates, is after 2 years after being on hormones. I think they did require surgery as well, like genital surgery. But after that...
You mean the old IOC rules?
Yeah, right?
The old IOC rules.
But the question I'm trying to get at is the teenagers that you're working with, what are they telling
Yeah, what are they telling you? I knew I didn't answer your question.
So I can't. I don't have a study. I don't have a survey. I've got anecdotal. So most of the people with whom I speak want to be included in a safe way, and like the idea of rules, because they want to be able to say that they're coming in a fair way, and that's so. I think that's what I hear. Figure out a way for me to participate. Tell me what the rules are, quote unquote, so that I can say I'm obeying those rules and everything is kosher.
Yeah, I mean, I've taken care of a lot of trans girls going through, and these are girls that you would never ever pick out of a crowd and assume that they were transgender. They are girls, and they're in things like volleyball and lacrosse and basketball, but also just mundane sorts of things, and they just want to play with their peers. I mean, they just want to play. They're not necessarily, of course they want to win, but they just want to play. They want to compete.
And that's what I think is unfortunate about the conversation related to sports. When you talk about Leah Thomas, you're talking about an adult athlete who is playing in a very elite form of sport. High school sport has a different purpose.
Absolutely.
High school sport should be educational. I know college, not really. But high school sports should be educational. I think there's a much stronger argument for, I think it's a whole different conversation than with Leah Thomas and then with recreation. And I think that's what's sad. The media has lost that distinction about, okay, what's appropriate in recreational play versus interscholastic versus intercollegiate versus Olympic.
I think that's a really great point. Yeah.
Okay, I think that wraps it up. Do you want to say a few words?
I want to thank you guys and Katie particularly, for a incredible conversation. And Katie suggested to me that maybe we're going to tell the program committee next year to put it on the program so that everybody can hear this. Unfortunately, it's not that easy to do with the program committee, but we'll work on it.
I know people.
You got some juice?
Well, it's not just an isolated thing anymore. Everyone knows someone who is trans or has a trans child or is, they're out there. And
Right, they always did. It's
they
now that
always
it's just
did.
that everybody now knows that they know someone.
And it's actually cool to say you do.
Exactly.
Well, thank you for the work you all do, honestly, and thank you for arranging this, Ken. Thank you.